Hello everyone, have a good day. I'm here to share my opinion, views, and about the experience I had in the area of urogynecology. And we'll be having a series on lower urinary tract dysfunctions in 3 parts. So today being the first part, the clinical evaluation and urodynamic test. This series is aimed at all the specialists working in women's health and urology. This will be even for the master's students working in various settings, especially musculoskeletal as well as the community. Even at times, the sports physio might need this, but for rare occasions. So we will have the clinical evaluation and the urodynamic test today. The next time it will be the micturition reflexes, and the last one we'll discuss what are the various management strategies for various urinary tract dysfunction. I'm very thankful to the physio OrthoTV to give this opportunity to share these views on a very less talked topic. So I hope you will get something out of this, and you can discuss with me. I'll share my email and the details at the end. So let's begin with today's talk on the clinical evaluation and the test. The test will be in brief. What we are going to do today is know what are the various lower urinary tract dysfunctions, what are the clinical evaluation available for it, the importance of urodynamic testing, and what are the tests in brief. In the next series, we will be going with the differential diagnosis and then the suggestion for management of lower urinary tract dysfunctions. As we know, there are dysfunctions, especially the stress urinary incontinence. There is a sphincter deficiency. There is overactivity of the bladder, the motor and sensory urgency. There could be a problem with the bladder compliance, the outlet obstruction, and the post-micturition dribble and incomplete voiding. Now the last two can be there, which are slightly not the part of the lower urinary tract itself, but it could be the other areas which are going to compress the lower urinary tract, which leads to post-micturition dribble and the incomplete voiding. So that is very important for us to understand. There could be dysfunctional voiding, incoordination, and pain during voiding. There could be a prolonged incontinence due to various causes, and one type of incontinence can lead to other incontinence types, which we will discuss later. There can be hesitancy and poor flow, and premature interruption of urine flow and incomplete voiding, which could also be there due to stress and various psychological factors. And it is very difficult to analyze such factors, especially women having several other problems. But we need to address these issues really very well and into the depth. So, what the complaints women come with, they leak urine, or they need to go to the bathroom frequently, or feel pain or discomfort while urinating, or feel sudden strong urge to go, or having trouble to start the urine flow, having problem to completely empty the bladder, evacuate, or saying that they feel that there is discomfort, possibly have the repeated urinary tract infections. So with any of those complaints, they come, we know that there is some problem with the lower urinary tract dysfunction. For the normal urine incontinence mechanism, we have the bladder, and we have the urethra, and we have the internal and external urethral sphincters. So to have there is a storage phase and the voiding phase, which is the micturition. So to have this satisfactory storage, it requires the intravesical pressure to remain less than the sphincter pressure. And we should have the elastic properties of the connective tissues of the bladder wall, ability of the detrusor to increase its muscle fiber length so that adequate compliance is needed. The reflex sphincter activity guards against sudden intravesical pressure increases, such as sudden standing, cuffing, lifting, shifting weights. So always it maintains the urethral closure pressure, and it keeps this higher than the bladder pressure. So all this happens with a reflex activity. We don't even think in a normal situation when everything is in place that we have to contract the external sphincters. It just happens automatic by the reflex guarding. And so when the micturition is appropriate, then the reversal of all this happens. And then there is a detrusor contraction. To have all this in place, anatomical positions of the bladder urethra have to be there, and the appropriate neurologic control. Without the anatomical connections, this is not going to work. So we need to have the anatomical positions of the bladder and the urethra in place, and all of the nervous control. We're not going to go into the details of the spinal cord injuries over here or the upper motor neuron lesions over here. That really is another specialty area which needs to be dealt with into details, which we can discuss at the time. We're talking about only the lower urinary tract dysfunctions out here. But the neurological dysfunctions also might require urodynamic studies several times. So, to begin with, several dysfunction factors. What are the factors which increase the bladder pressure? Because bladder, there is a resting pressure and there is a compliance of the bladder. So whenever the bladder gets full, starts getting filled, this pressure does not increase. The pressure remains constant and the bladder allows itself to get stretched. Whenever, even in the increased abdominal pressure, the compliance of the bladder is there, which itself helps in allowing to maintain this pressure without disturbance. But if there is a compliance of the bladder, which gets reduced, then there can be other problems. Also due to various dysfunctions and having several times the frequency, so many times, that might reduce the bladder capacity itself. The bladder then is not getting as much enlarged. So that leads to various problems and further leading to having more frequency, because now that the capacity it has reduced, so that the person then feels the urgency and requires to go. So all this needs to be considered. What are the factors which increase the bladder pressure? So with reduced volumes also, that the pressure is now going to increase. There are various factors which contribute to the urethral closure pressure. The intrinsic sphincter, which is a factor where that closure pressure will be maintained. The length of the urethra is very important. The uretrovesical angle is a particular angle for the bladder to the urethra, which naturally creates a tension around the urethra, and immediately leakage will not be there due to the angle. The pressure, where the abdominal pressure transmission will be maintained if there is a cup or anything which increases the abdominal pressure, this pressure gets transmitted equally to the bladder and the urethra if the urethra has not displaced. So if the pelvic muscle weakness is there, if there are other areas which are going to lead to the urethral displacement, then this abdominal pressure equally doesn't get transmitted to the urethral meatus. And hence what happens is the bladder pressure increases, but the same pressure doesn't apply to the urethra and the seed. Hence, then there is a disturbance between the bladder and the urethral closure pressure, which leads to the stress incontinence. So, external urethral sphincter supports are really important in maintaining this. Otherwise, there would be the dysfunction. So, if we come across any of the lower urinary tract dysfunctions, we need to have an initial assessment, very vital. The symptoms of the person, about the frequency, nocturia, urgency. We should know what is normal. Normal frequency, 6 to 8 times in a day, and once in the night after age of 60 in women. After age of 75 could be twice. So urgency at times rare with the psychological. Otherwise, normally urgency will be felt if the bladder is too full. So during this, it's important to understand what is the person complaining about the frequency at night, the person goes an urgency. Does the person have any voiding difficulty? Does the person feel that she feels that the bladder is getting completely emptied? Because all this leads to further problem. If the bladder doesn't get emptied completely, then the bladder will get full as in the next time. The urine flow or the urine will normally is between 1 ml to 2 ml per minute. In situation depending on the intake of the fluid, depending on the atmosphere and the climate variations, and hence the bladder is going to get full. There is a bladder capacity which will reach early if the person is not emptying completely. Also, keeping the residual urine becomes a more problem that it irritates the bladder walls. So if there is a residual urine, this is going to cause a problem because that could lead to the overactivity and the sensory problems with it. So one would lead to other problem, and then there can be a mixed picture. So if the person gets stress urinary incontinence, the person first tries to void more times so that the pressure, even if it is there, the leakage will be only less. So this is what happens when the person initially starts getting the stress urinary incontinence, that tries to keep the bladder empty and tries to reduce the intake. So this happens naturally to try to protect. But indirectly, this leads to more problem because the concentrated urine irritates the bladder wall, and that might be a cause where the overactivity will be there. So it's really important that we should have a health promotion activity, and we should teach women that if they find any of this, they should take an advice and not to try to self-regulate this because that complicates further. So if they come with a problem, with initial problem, all this needs to be checked for them. There are certain other problems such as dysuria, painful. This can be due to the medications they take, or sometimes they can have diabetes. There can be hematuria. All this needs to be addressed very well. So we need to have a urine dip test done before we even do an internal vaginal assessment. So it's very important to have other history, the surgical history, the obstetric gynecological history, and the duration and the severity of problem. So it is very important to know for what are the underlying causes it could be. So all this initial assessment would then be into the details and need to be noticed. So patient history and examination enables us to select the proper intervention. There needs to be a pelvic floor muscle evaluation, which is very vital, so that we know what is happening to the external sphincter. Because the pelvic floor muscles have its skin on the mesh into the urethra, and this is the external urethral sphincter, which is governed by the voluntary effort. As we know that the bladder or detrusor is only an organ which is under voluntary control. So it plays an important role to understand the nature of this organ, which is so special, which is a smooth muscle being governed by the urethral sphincters. And hence there is an intricate reflexes which govern this whole system. To make things simple, we ask these women who come with the problem saying, I go frequently and I go every hourly. So avoiding diaries, at least for the first time, we could ask them to take, like yesterday, could you remember? So it becomes difficult to recall. And hence, most ideal thing we would like to have with them is the frequency volume chart. Now, this takes a lot of effort from the patient side to have this chart being filled, because this is going to be very, very important, and it doesn't require any money. There are no side effects of doing a frequency volume charts. There is no problem as such with it. The only problem, it needs to be the self-regulation and documenting correctly. So this needs to be highlighted, and women need to be educated how to do it. The other parameters which are also studied is the type of pads, if they at all use for the incontinence, if they have, and the number of pads they need to change, and what type of fluid they have. There has been various studies which say avoiding diarrhea is a very reliable and a valid measure to know about the overactivity, including the urge and the urge incontinence, nocturia, and other things. The data obtained from the frequency volume charts of normal females showed that what is the mean voided volume and the frequency. So even the normative values are being demonstrated. Equally, there is a cup stress test, which is also a reliable tool, and you can ask them to do for themselves as well. Having said this, I would like to have some time discussing this frequency volume charts. So these frequency volume charts are the best demonstration of the bladder capacity. So without even needing the urodynamic studies, what is the maximum bladder capacity can be studied very well with this frequency volume and the incontinence charts. So this additional information required is there for them to take. If there was a leakage with the stress or leakage with urgency, so S or U, they can just put it over there. Now it needs to be done. We have this chart. There are ready-made charts available. We give them with all the detailed information that they need to write down since in the morning when they got up, and they need to measure it. The urodynamic lab, they have to measure and take them anyways. But if we are not considering any urodynamic test, this is very, very great details depending on how much was the maximum volume which was collected. In this can be really giving us the capacity. how many times the person needed to be voided, the person will tick. So if the person gets up at 6, would be the first tick. Next time, whenever the person goes in that hour, the person has to tick that had to go to the toilet and how much. For the capacity maintenance, it needs to be in a privacy. There needs to be a measuring jar for it. And the person also has to put a tick when the person has any fluid intake, whether and mention water, tea, coffee, if it is possible. If it is not possible, at least to take it that how much, 100 ml, 200 ml. If a person mentions all this correctly, it gives the evaluator a great idea about how much is the problem with the person, and women get amazed to see themselves that how much problem they were facing. Sometimes I've seen the ticks about 24 to 30. And the person said, I never realized that this is what is happening. Other times it was not so many ticks, but it was there that the person felt, I need to go, I need to go. But when put into the ticks, that was not that bad. So looking at the tips, at times some women, their life was like they feel they are just attached to the toilet all the time. And when they put all these ticks, it is very surprising to them. So it needs to be there for minimum 3 days, it is said. So keeping these diaries for 3 days, it's very, very stressful. But if it is done correctly, this gives a quite adequate information. But this needs to be gone with the great information. So we get to know that how many number of times the leaks, what are the causes for the leaks according to the person, and the frequency, any medication the person is taking, or having so much of the hard drinks, coffee, which leads to these problems. So we need to have all this information in tests. In our clinical scenario, along with having the details of the frequency volume charts, along with having the type of pad the person is using, we can ask them to undergo this pad test. Normally, a 1 hourly pad test can reveal many things. So the pad is pre-wetted and person puts it, takes as much water she could drink and sits for about 30 minutes, then does those activities which are provoking the leakage, like cupping, going up and down stairs, bending, depending on the age and the activity, jumping up and down. So whatever the activity leading to the stress or the leakage, the person does. Or washes hand with cold water, enters into a cold room. So whichever the symptoms the person experiences, the pad test is taken. The pad is then weighed again. And if it is more than 7 grams excess, then that much is the leakage within that much time. So 1 hour pad test has been standardized. Its efficacy and its reliability, validity has been done. But at times it can be also overwhelming. And if the person is ready to do, can do 2-3 times at her own pace, at her own home, and let us know what the person would come up with. But it needs a special weighing scale because it has to be in grams. So with this pad test, along with this, as I said, for knowing about the condition of the external sphincter, the pelvic floor muscles play a major role. Also, with this displacement, or there can be the vagina, which can be having the laxity, where we do find that there can be the urethral or the bladder displacement into the walls. So whenever there is the cystocele or urethrocele, that could be leading to the lower urinary tract dysfunction. Hence, it's very important to know if there is such a displacement there. So we should be doing an internal examination, which is of a gold standard, or we can do another objective measures, such as the electromyography, or we can have another test which can be knowing about the pressure. So we can have many tests which we have already discussed into the previous lecture, that where is the testing needed for pelvic floor muscles and which are the way how we can do this. So there are simple tools available which will measure the pressure, and we'll know about the pelvic floor muscle strength. The pereniometer is such a device where we can take this in as an objective measure. Plus, there are self-assessment tests, such as doing the urine stop test, which again correlates very well. So we can ask them to do a self-test if the person is not at all ready for an internal examination. We need the permission, but we need to convince the person for it very well. So there are various procedures for doing the pelvic floor muscle internal testing, which are already been discussed. So we get to know what is the pelvic floor muscle strength and endurance, which will help us in determining the management strategies. So now coming to the further test, the urodynamics. So there are the lab tests, especially done in labs with special technicians and urologists at times being present, or it needs to be specifically done in special scenarios only. So this testing is warranted where there are complicated incontinence symptoms and urinary incontinence which is not really managed with the treatment, or the person is giving conflicting history and the physical examination results. There are various areas which only the specific urodynamic test will be then undertaken. The goal of the urodynamic test is to reproduce the patient's symptoms and understand that very objectively. Though this provides a physical explanation of the cause and objective assessment in this case. So this, we are able to demonstrate the type of incontinence, if any, to differentiate between sphincter weakness and urodynamic stress incontinence and involuntary bladder activity, or the detrusor overactivity, so that the most effective method of treatment can be selected. Because the stress incontinence, what we see to the stress incontinence is on a pressure when there is a leakage of urine. But at times, it may not be only the stress which gives this, but there are other factors that the person feels if I cough or sneeze and then there was a leakage. There could be overflow incontinence, or at times that the bladder also then contracts. So in absence of detrusor contraction, whenever there is a leak on increased stress, that is the genuine stress incontinence, or it is only tested with the urodynamic studies. So we are able to differentiate the type of incontinence, and we are able to differentiate what type of the lower urinary tract dysfunction with having the urodynamic test. Why are we discussing this urodynamic test results? Because as a physiotherapist, we don't do this test. It requires special specialists to do this test. But when our patients come back with the urodynamic assessments, we need to interpret these findings correctly to incorporate that into our management goals. Hence, we need to know what are the different urodynamic studies being held. And it is important that it is recognized that considerable discrepancy between the patient's symptoms and urodynamic diagnosis also have been there. Although these tests are widely used, it's managed only the management discussing only from the test is not possible. So we need to have both in situ, the clinical evaluation, the patient's history, patient's need, and the urodynamic test. All these three need to be considered for talking about the management. Also, there were a lot of studies to support that only if surgical option is needed, then the urodynamic test will be carried. So if there is a surgery now indicated, then the urodynamic studies should be carried out. Because urodynamic tests are not without a distress, it is an invasive method where there are various tubes inserted into the bladder, urethra, and the rectum. This is going to cause a considerable distress. There are chances of getting infection after this. The psychological stress the person undergoes during the testing and the psychological status can have influence the bladder behavior and the urethral closure pressure. So there should not be any infection during that stage. There should not be any other problem during the urodynamic test being carried out. So these urodynamic tests are, apart from 1 or 2, they are not very simple, they are invasive. Hence, very keenly, we have to see when it should be done, whether we should refer the person for getting urodynamic test. So if we find that the conservative management is not working, then we should be having this additional information to get to know where the person should have a better outcome. There are guidelines set by the International Continence Society on the advice on urodynamic protocol, when to undergo these urodynamic investigations. For every patient, it needs to be a thorough evaluation, the urological examination, gait assessment, sacral sensations, and relevant reflex testing. So, female patients should have a pelvic examination interval done, and patients investigated for lower urinary tract problems are expected to complete a relevant validated symptom score, includes a bother to life indicator or a quality of life assessment, functional assessment, has to undergo a complete 3-day bladder diary with the volume chart. Then only they arrive at doing the urodynamic test. Urine analysis is always done before the urodynamic testing. So if any chance of infection, already having infection or blood sugar levels, all this is going to be determined first. Because if the person has a high glucose levels, that also leads to small problem with the neurogenic type of bladder, because that can be a problem with the diabetic patients, severely diabetic patients. So we need to check what are the medical conditions the person is having. We'll go through the different urodynamic tests. When we get the results, we should know what the tests are. So, cystometry, urethral pressure measurement. So, cystometry is the gold standard. The urethral pressure measurements, the leak point pressure measurements, the uroflowmetry, post-micturition residual volume by ultrasound or a catheter, transvaginal ultrasound of bladder, neck, and end of filling phase, and the pelvic floor muscle, transvaginal ultrasonography, the video urodynamics, and the ambulatory urodynamic monitoring, or the electromyography and the nerve conduction velocity studies, which are the electrophysiological tests, which can also be conducted in the urodynamic labs. So the gold standard cystometry is a simple multi-channel or subtractive study of the pressure, the vesicle, the relationship to the bladder during urine storage stage. So this is the filling cystometry and during the voiding cystometry. So what is done is there are the catheters with the sensors being inserted into the bladder. The second one, the sensor is in the urethra. There is another catheter which is into the rectum, and there is a sensor into the rectum which measures the abdominal pressure. So the abdominal and the pressure in the bladder, subtraction gives us what is the pressure inside the bladder. So we can measure these pressures while the bladder is being made filled by the catheter, through the catheter. Slowly the water or a special fluid is being put into the bladder. So the person is into a semi-reclined position and looks at the screen very well. So this gives a great idea about the bladder sensation, about the bladder capacity, the stability of the bladder, and the pressure changes, the pressure types. So all this can reveal a lot. So slowly when the water is filling into the bladder, what is asked, the person is asked to say that, do you feel that there is now the fluid in the bladder? The person evacuates the bladder first to come into for the test. And then the bladder sensation of first filling, the person may notice something between 50 to 100 ml. But normally at 150, the person will feel, yes, I feel that the bladder, there is a fluid. During this time, now the rate of this fluid or the water in this bladder needs to be very specific, cannot be very fast. Slow can be okay, but the time required will be so much more. So with this rate and the pressure, the person is being then asked to check when the person feels the bladder is now full. The fluid or the water is being into the bladder. So these pressure changes are being noticed. So during the storage phase, the bladder is normally stable. So there is no pressure change observed. If there is a pressure change observed, that reflects that the bladder is contracting, and it reflects the overactivity of the bladder during the storage phase. So then we can see that that is a problem, and then the leakage is observed because the bladder is contracting. If the contraction force will determine what will be the leakage there. So maximum sensation, the person asks, the person will say, now I cannot tolerate any more fluid in my bladder. So that is the functional capacity of the person which is tested. Still, they try to fill in more to check the physiological capacity. But to some degree, it may or may not be possible to go further. The person is asked to know the appropriate increase in the pressure during this voiding thing. Provocation testing is performed when the bladder is getting full. So by asking the person to cough or doing increasing pressure and to see there is any leakage at this point. So these provocations are done and it is checked whether there is an involuntary or voluntary contractions happening during this cystometry test. So this cystometry will talk about the sensation of the bladder. Whenever the bladder compliance is a problem, gets overfull, the sensations can be reduced, or if the capacity is reduced. If there is overactivity, the stability during storage phase is at a stake. The pressure generated and the compliance can be checked. So this normal cystometry shows a low and stable pressure of the bladder during the filling phase. So that is really important to know. Next, it is tested is the leak point pressure measurement. and the pressure within the bladder at which the leakage of the urine is observed. While the bladder is being filled with the water for the systometric test, the bladder may contract suddenly and squeeze some water with or without warning. So a manometer measures the pressure inside the bladder when the leakage occurs, identifying the leak point pressure. Cup or shift of the position actions also help to evaluate the sphincters. So this leak point pressure measurement is done during the systometric test. There is also urethral pressure profilometry, or these measurements are done to measure this pressure of the closure of the urethra at rest or during stress. So catheter with these two separate transducer is placed, with the top one in the bladder and the more distal one in the mid-urethra, and connected to a gradual infusion. In the dynamic test, the catheter is withdrawn until the maximum urethral pressure is reached. So it is used to elicit the leakage, when it will be at what point. So it is called as urethral pressure profilometry. It gives us how much is the length of urethra, what is happening to the external sphincter. So this profilometry helps in knowing what happens between the bladder and the urethral closure pressure. The next test in the uroflowmetry appears to be very simple but very informative test in knowing about the volume and the pressure. Now this uroflowmetry is the recording of the volume of fluid expelled via the urethra and the time during voiding. So the volume of the urine left in the bladder after the voiding is then tested. So it's like a person is sitting similar to his or her toilet, western commode type, and there is a pressure sensor which is attached to this toilet there. So when there is the micturition occurring, how much is the volume which is micturated and what is the pressure is being checked very well. So we get to know the compliance of the bladder very well when this test is done. So how much is the flow and how the pressure and the volume gradient is there. So we understand how much is the bladder contracting with what strength, or if it is very slow and the urethra is not being able to control at times the dyssynergia between the bladder and the urethra. That will be evident if it is not a continuous flow. So we get to know a lot from the uroflowmetry test, and it is non-invasive. So this non-invasive test reveals a lot to us about the pressure and the flow. How much is the time required for the ml of the urine blast. Next comes the video urodynamics, which is done in very rare occasion, but it is a radiologic imaging or even ultrasound pictures being taken. So instead of water, a special fluid which will be captured by the radio opaque contrast is used, and all this testing is done very dynamically of what is happening inside the bladder as well as during the leakage. So all this filling of bladder with this radio opaque contrast and use of fluoroscopic screening during filling, provocation and voiding is termed as video urodynamics. This allows urinary leakage to be observed together with anatomical details of outlet during provocation and voiding. Now this video urodynamics or cystometry, all this is considered as very unnatural sometimes, and what regular response the person has, it may not give us the same picture clinically, and hence it may not correlate a number of times. So this has led to a very special test, which is again very rarely done, But we must know also very high specific tests where they are trying now to have ambulatory urodynamic monitoring. That the person does this for about 2, 3, 4 hours and about 2 maturation cycles. So this is performed under physiologic bladder filling and the circumstances where the patient is free to move around without any artificial filling of the bladder. The patient's bladder fills normally with its own urine production, because filling the bladder externally and keeping the speed, because if the speed is more, that can also irritate the bladder, and the bladder may normally not be overactive, can respond in the sensory that way. So it's very important that it needs to be filled naturally with own urine, and it can be more representative of day-to-day life and may give more accurate information. So it is done for at least 2 or 3 filling and voiding cycles and captured over 4-hour period, during which the patient drinks normally, keeps a diary of symptoms and events, while a portable recording device continually measures the intra-abdominal pressure and vesical pressure. But still it is under investigations and further needs to be going into the details to see whether this is more appropriate than doing only the video urodynamics or systometric studies. So again, this needs a lot of precision in putting the catheters, and the person is moving around with all this. So still this is under review, the ambulatory urodynamic monitoring. But this can be the next level, which can be more natural setting, and this can determine a lot of other problems of the lower urinary tract. Also are being discussed about the electromyography and the conduction velocity test, where there is a direct measurement of contractility of the muscles connected with the continence, the urethral sphincter, and the sphincter or the pelvic floor muscles. So there is only the EMG, which is not the needle here. It is used as the external electrodes, and the NCV is, of course, with the surface electrodes. So surface electrode electromyography, or NCV, is studied for the pudendal nerve and being checked about the condition. So whenever we are saying we will do all these studies and we will get all the interpretation when we do these reports and our own clinical findings. So from here, we get to know about how to evaluate and interpret this clinical evaluation in urodynamic test. So we'll go through getting back into how to interpret with the symptoms and what the findings are, so that we can apply our skills for determining the management part. So before this, just for the quick revision, whenever we say we are talking about urodynamics, we are talking about continence mechanism, it all depends on how much fluid also the intake. So normally on an average, 1 to 2.5 liters in 24 hours can be there. For some who are really doing a lot of exercise and things, can go up to 3 to 4 liters. So we have to check what the intake of the person is and the type of intake, because the frequency and all this will depend on the fluid intake. It will also depend on the climatic variations. So we have to know all this plus the medications the person is undertaking. So in total, when we know that the functional bladder capacity, normal values are given as 400 to 600 ml, but it could go to 350 for the aging population. We know that the normal voiding frequency is 5 to 7 voids. At a younger age, there is not at the night. After the age of 60, once a night, and more than 75 might be twice a night. All this will also depend whether if the person is having the higher blood sugar levels and if on the medications. But we now get to know from the person's symptoms that what is this frequency if there is urgency. So this is the normal bladder filling pressure. So during the storage phase, the bladder pressure should be less than 15 centimeter of H2O. Now this pressure slightly varies between lying down, sitting and standing. But during the storage phase, the bladder pressure should not increase more than 15 centimeter in any position, unless there is a problem. The urethral closure pressure at a younger age is around 50 to 70 centimeters H2O. With aging and menopausal age, it could go to 40 to 45 centimeters of H2O. So we already know that during storage phase, this is the bladder pressure, this is the urethral closure pressure. The female urethra length is around 4 centimeter, but can be varied slightly with the 6 millimeters of diameter. We should know the length because that can be also another problem when we talk about the symptoms and how to interpret the findings. This time to void normally on a normal uroflowmetry studies, it depends on how much is the bladder full. So it goes on an average with 25 ml per second. So it's the volume per time, how much the flow will be, and a normal compliance of the bladder. So this is the normal physiology, capacities and pressure with the frequency. Now, from all these findings and the studies, how are we going to justify and interpret this? So as we have seen, the storage symptoms like frequency, nocturia, urgency, we can see all that with the charts. So it's very important how the person has filled up the chart. In the chart, how many ticks are there on an average in the 3 days at least when the person is making this chart? So we get to know whether at times at night, how many times the person is going. And if the person feels that urgency has to be asked to put up that if possible. And when was the leakage occurring? So it is the intake output volume. If without volume also we can do this knowing about what is the frequency and the incontinence type. So if there was urgency and the incontinence happened, the person will put up U there, or if it was on a cuff, so the symptom of stress incontinence, the person might write just I. So when this ticks, we find how many times the leakage was there during the day or at night, and what is the time. So this intake output chart is very, very invaluable. So we need to take our time in explaining these charts to the patients. So in the first appointment, we have to actually give them an hour or so, if possible, but 45 minutes are quite justified. So appointment for 45 minutes, when we have to talk and know about the symptoms, taking all that detailed history. So filling up that chart doesn't require any money, but it requires the continuous timely entries by the person, because that might reflect something very wrong. So all this can be tested. Now the next one about estimation of how much the incontinence of the person is. The pad test would definitely, so if it is more than 7 grams, it could be anything between 10 grams to 65 grams or even more, the leakage has been observed and put in. So it gives us very important and objective problem about how much is the leakage of the patient. So all this will be the clinical test, evaluation of the symptoms, asking about the frequency, how many times, and confirming that with the chart, intake output, if at all volume is there, That will tell us even about the bladder capacity, the volume. But if further problems are there, and if it is very long standing urinary incontinence and have been tried a few measures, then of course this is cystometry. So when we say it is the stress incontinence after testing the cystometry, it is also called as genuine stress incontinence. A term is given like this when the bladder is stable during the storage phase. So it doesn't get provoked. On provocation also does not increase the pressure inside the bladder. So on the cystometry, if the bladder is stable, we know for sure that it is not the overactivity, and the treatment can be then jotted accordingly. So it's called as urodynamic stress incontinence or genuine stress incontinence, because according to the International Continence Society, the urinary incontinence of stress incontinence is there's a leakage of urine because of the stress in absence of detrusor contraction. And this absence of detrusor contraction can be confirmed on cystometry. So if they're thinking about doing any surgical procedure of repairing of the sphincters and all, they would like to confirm that the bladder is not unstable. So it's very important if any surgical decision is not to be thought for the person. Still, of course, a 3 months conservative trial will be given. The pelvic floor muscles need to be strengthened, so we'll discuss that. But they want to ensure the stability of the bladder before the TVTT or other procedures. So this stress incontinence also can be checked with the urethral pressure profilometry. So while withdrawing the urethral catheter with the sensor, the person is asked to contract and the urethral pressure throughout the length can be checked. So the sphincteric dysfunction can be studied by doing this simple test or the cystometry. So if it is found during the urodynamics test that there is overactivity, so this cystometry will show that there was a pressure change with or without provocation. So with provocation, with the sensory, motor, with provocation. So at times it is observed in the cystometry, the person is asked to cough vigorously and it is checked that the bladder pressure increases and the bladder, that means that the bladder is contracted. So that can indicate that there is overactivity. The person's symptoms are also will be also there, but it will be confirmed now, okay, on provocation of the test results. Now, on all these symptoms findings, the person's diary, the pad test, and cystometry, if at all the urethral pressure profilometry, if both the types of the symptoms are there with stress, incontinence, or overactivity, there can be a mixed picture. So the person comes with both, that I have sensory urgency, I leak if I don't reach the bathroom, or if I enter into an cold, very cold AC room, or there are other sensory triggers. So there is a leakage and I cannot just control myself before reaching to the toilet, there is an accident. Plus, the person also says that if I bend and lift suddenly, or I cough, or I just do a small jump, there is a leakage. That is the stress incontinence. So we get to know exactly how much is the extent, how much is on the pad test, the leakage there, and what type, whether the bladder is stable, at times unstable, both. So we will get to know and estimate into details subjective and objective measure. So we can analyze this, and in the further, we are going to talk about what we can offer to these women. So during voiding, there are certain symptoms which can be there due to various dysfunction. So again, to summarize, if the person has hesitancy, intermittent urination, or straining during voiding, or poor flow. These are all the symptoms the person is going to talk about. And now that this will be confirmed by doing the urodynamic stress test. So the bladder compliance also can be studied. If there is dyssynergia, it can be checked on the uroflowmetry. So uroflowmetry is another urodynamic test. Now it's not invasive. The person is evacuating the bladder as naturally sitting on to the toilet seat, but the person should be relaxed and feel comfortable, and it should be as natural as possible. So about 2 times this uroflowmetry is taken. So we get to know how much volume is there into the time. So if there is a poor flow, that can be determined by this uroflowmeter. So if the flow is less than 10 ml per second, so the time required will be so much. Also on the graph, we find that the flow is there, then it gets interrupted. Again, the flow is there, it gets interrupted. So that can be there due to the dyssynergia, which are again a complicated issue. There can also be a problem with the outlet obstruction. So this poor flow, or the person has to strain, that can be there due to the outlet obstruction. Outlet obstruction can be there due to the prolapsing bladder or the urethra. So urethrocoel or cystocele can bring this outlet obstruction. There can be another growing tissues into this area. We have to be checking that again. So this outlet obstruction, the person might have to strain. Also, there can be incomplete voiding or residual. So when the person says, I'm not, in spite of the uroflowmeter or passing urine, the person doesn't feel that the voiding is complete. So feels that there is some urine still left. Now, how much is the residual is very important to be checked, and that can be checked by doing a sonography test. So how many ml post voiding is the residual urine? Or at times, if sonography is not available, they used to insert the catheter and check how much volume is drained into the catheter. So residual is another problem which leads to several, it triggers many things. But this can be there even during urine infection. So as I said, it's very important to rule out the urine infections and other possibilities. Where there is another growth, there can be the outlet obstruction, and that needs to be addressed. But ultrasonography and real-time ultrasonography can check what is giving this outlet obstruction and why is the person straining on. So we have to find out whether that obstruction is there due to the prolapse, how much it is. Or there could be the post-micturition dribble. So these post-micturition symptoms also talk about the disturbance into the urethra. So if there is a post-micturition dribble, the person may feel that it's emptied, but on changing the position and standing again, there is a dribble. This can happen due to the displacement of the urethra and the pelvic floor being very weak to control. So once the leak is there from the internal sphincter, the external sphincter and pelvic floor cannot control this dribble. So when there is a displacement of the urethra and bladder occurring, we do find that there is a post-micturition dribble. This could be evident again with the uroflowmeter, exactly how much is the dribble. Okay. So it is a supportive dysfunction of the pelvic floor muscles or something obstructing that. And when the position change occurs, this dribble is seen. So we have now seen all the symptoms and the dysfunctions. Now we know how to analyze this subjectively and objectively. We plan this management. Before we are going to plan the management in the next session, I'm going to just highlight on how the micturition reflexes, what micturition reflexes are there in the normal, what affects this micturition reflexes, and how we can make use of these reflexes in our management, which will lead to a better control and cure. So thank you all for this patient listening into this topic, which is very, very important. The we can have all this discussion on and on. If we understand the mechanism clearly, the planning can be made really well. So I will see you in the next session. If there are any queries or some suggestions or the feedback for today's session, you can contact me at my email or on LinkedIn. So that will give me a feedback if I have to, explain anything further. So I thank the Physio TV organizers, the Sancheti Healthcare Academy, to give me this chance to share my thoughts and the experience which I have in this field. So we can do see that the person does become relatively free from the incontinence problems and can lead to a better life. So thank you again and see you next month with the details about the mechanisms and the reflexes of micturition. Thank you. Check for the dates in the November for you.